Hi everyone, welcome to the Block 1 Lightning Talks on Service Development. My name is Johnson. I'm joining from the traditional ancestral unceded territories of the Musqueam people. And in today's session, you'll be hearing 4 presentations from our speakers. Each presentation is 5 minutes long, with slides that advance after 15 seconds, followed by a 6 or 7 minute Q&A session. If you have any questions, you can ask them through the Q&A feature on Whova. You can see an Ask a Question button on the Whova page for this session. And if you see any questions you like, please give them a thumbs up, and I'll try to ask those first. Also, please feel free to put questions on Whova throughout the presentation, so we can immediately start answering them once the presentation is done. And lastly, please make sure your questions go on the Whova Q&A and not the Zoom chat. After this session, you can vote on your favorite talk for this blog through a poll on Whova. The winner is going to receive a certificate, free registration to a future conference, as well as an invitation to present at a future conference. The winners are going to be announced on Whova before the conference's closing remarks at 3:30 Pacific Standard Time. Right, and without further ado, I'd like to pass it off to our first speaker, Dr. Steph Kershaw, for a talk, Development and Evaluation of Cracks in the Ice, an online resource for Australians affected by crystal methamphetamine. Please take it away when you're ready.
Thank you. So I'm joining from Australia today, and it's 4 a.m. in the morning, which is a wonderful time to be joining you all. Today I'm going to be talking about Cracks in the Ice, which is a digital public health initiative that launched in 2017, and it aims to disseminate evidence-based information and resources about crystal methamphetamine, or as it's more commonly called here, ice. I can't tell if my slides are advancing, are they?
All good now.
Okay, great, thanks. So the resources and information on Cracks in the Ice is accessible to anyone, anywhere, at any time. And there's a particular focus on supporting families, health workers, and communities who've been impacted by the drugs, as well as school-based prevention resources. And we have a number of tailored resources for each of these groups, as well as people with lived experience. Although we are currently filming some videos to make more resources. We also have a companion smartphone app, which is essentially a condensed version of Cracks in the Ice that's functional even when offline, so people can still access information even in areas where internet is unreliable. So methamphetamine is a global concern, and Australia has one of the highest rates of methamphetamine use. And recently we've seen a rise in the use of crystal methamphetamine, which is often the more pure form of the drug compared to the other forms, base and speed. So in association with this, we've also seen a rise in methamphetamine-related harms, including increased helpline calls, hospital admissions, as well as drug-related deaths. So since the launch of Cracks in the Ice, we've had a really high level of engagement with over 800,000 unique users visiting the site, over 1.6 million page views, 7,000 clicks to download the app, and 22,000 people have engaged in the webinar series. So in 2019, we decided to run an evaluation survey, firstly to evaluate whether Cracks in the Ice was meeting the needs of its end users, but also to gather information on knowledge and attitudes about crystal methamphetamine. And the survey was completed by 2,110 Australians across the country, and we had an average age of 36 years, with 59% being female, and a good response from metropolitan, regional, and rural and remote. And many people had been affected by crystal methamphetamine in some way. There were 27% who reported previous use, and 41% reported having a family member or friend who they thought might be using. So overall, the findings were positive in the survey, with 94% of respondents finding Cracks in the Ice to be useful, and most participants said that they would recommend the site to others, regardless of whether they had seen the site before or not. And one of the other major findings that we had was that, sadly, negative attitudes towards people who use the drug were common. For example, 71% of participants agreed with the statement, "I would avoid people who use crystal methamphetamine wherever possible." We also did some pre-post tests among people who had never seen Cracks in the Ice before, and we found that exposure to Cracks in the Ice resulted in significant increase in knowledge about the drug, which was good. And we also found that exposure to Cracks in the Ice led to a decrease in negative or stigmatizing attitudes. But we do need to look into this a bit further to see whether those changes are temporary or maintained over time. And it's really important that we decrease stigma, as the survey also found that 39% of people who reported having ever used crystal methamphetamine had felt discriminated against or mistreated at some point. And this increased to 70% among those who use the drug frequently, which we defined as at least once a month. And there are a number of stories of discrimination from people with lived experience. And so I hope this talk has shown why it's important to have digital initiatives like Cracks in the Ice, as they have the ability to overcome structural, geographical and attitudinal barriers in alcohol and other drug prevention efforts. If you would like more information about the research studies presented today, you can message me or you can check out these two published papers that came out last year, one in JMIR and one in International Journal of Drug Policy. And to finish up, I'd like to just acknowledge our funders, the Australian Government. I'd also like to thank the wider Cracks in the Ice team, as well as our many collaborators and the many community members who continue to put input into the site. And if you'd like to know more generally, you can visit the website or download the app, and you can also follow us on social media or subscribe to our mailing list. So thank you, everyone. I hope you found that interesting, and please let me know if you have any questions.
Thank you, Steph, for the great presentation. Please remember to put your questions in the Huba Q&A. So we have a question from Colton. Great presentation. What's next for Cracks in the Ice?
Great question. We've got two things in the works, and my cat is about to join us. Apparently he's very excited. We have just launched a special portal which has information and resources for Aboriginal and Torres Strait Islanders of Australia. And we are also starting to expand our resources to support family and friends who are often affected by loved ones' use of crystal methamphetamine, but there isn't many traditional supports for them available currently.
Awesome. Were there any efforts made to ensure people had access to the technology to access the resource?
Not specifically in this study. In Australia, we do have a high percentage of internet users, but it definitely is a bias in our study. And we could potentially use paper and pen copies in future to make sure that everyone has equal access.
Awesome. Next question. How has this awareness work informed any program development for treatment providers?
Well, it has helped to highlight the fact that stigma is very common, particularly among health workers. So we're hoping to see some translation, particularly in the areas of policy, but also around work in health worker promotion to help increase people's knowledge about the drug and also decrease their stigmatizing attitudes.
Awesome. I have a question. What kind of strategies have you been using, or at least considered using, for Cracks in the Ice to increase or like maximize its reach?
We have a number. We have social media. We've also done a major social media paid campaign, which was incredibly successful. We've also tried Google Ads, which were less successful. And other than that, we have hard copy brochures and booklets. So we've done mail outs to a lot of AOD treatment services, a lot of our primary health care networks, as well as hopefully in the future be able to have a marketing company come in and advise us on how to best promote our resource.
Awesome. That's all the questions for now. I'll give everyone a little bit to see if there's any more questions. And if not, we can move on to the next lightning talk. And also, if there's any questions that are not answered in the lightning talk or in the Huba Q&A, rather, I believe the speaker can also answer those directly in the Q&A as well. or in the chat. Right, if that's it for questions, let's move on to Colton, who is presenting on the Lifeguard app, connecting users to the right services. Please, when you're ready.
Thank you. Good morning or good early morning for those of you in Australia or stuff. So my name is Colton Calderoni. I'm the Senior Product Manager at Lifeguard Digital Health. So I manage the development and delivery of our applications and products. So just here today to give you a bit of an overview of what our applications do and why we're here and some of the initial successes that we've had. So the Lifeguard story. So Lifeguard's been around since about 2017. Our CEO and founder, his name is Jeff Hardy. He was in addiction treatment for pretty severe alcohol addiction. And while he was there, he met lots of people, but one of his good friends, Evan, who you see here. And while they were both in treatment, Evan decided to actually try crystal meth one more time. And unfortunately, it took his life because it was laced with fentanyl. So Jeff said, you know what, why don't we apply some technology to this opioid epidemic and this problem that's claiming so many lives and see if we can save some. So the initial version of the app started as the Lifeguard timer. So when you open the app on your phone, you see this timer. I'm moving from left to right here. You start the timer and the app will pull up your current location. You'll confirm the location and you can enter in any additional details, perhaps your floor, apartment number, area description, and then you start the timer. Once that's confirmed, and it starts at 60 seconds. You can also pause and extend the timer depending on how the person's using their substances, to give them a little bit of clarity around that. And then consume the drugs. And if you're unable to stop the timer at the end of the 1 minute or however long you've adjusted it to, the information that we entered at the end will be sent to 911 and the alarm on the phone will go at full volume. So we're assuming at this point now the person has overdosed. So we then now send a text to voice packet to 911 dispatch centers to the most appropriate location. And at that point, the dispatcher can then enter the information like they do a typical 911 call, and they can dispatch out ambulance and paramedics to that person's location. The alarm will stay on until somebody actually stops it. This process since 2017 has saved up to 44 lives now. And so we've had some great success stories. Some people who have used it several times, more than once, and been saved more than once, and people who have even moved on and gotten treatment after using Lifeguard and having their life saved from this application. So we're also looking to expand to other features. So what else do people might need? So we're looking at push notifications to send out alerts about drugs or toxic substances. We also have services near me where people can connect to mental health and well-being services in their physical location. We also provide other online telehealth resources and different educational guides. We're currently available in British Columbia and Northwest Ontario, and we have another agreement with the Métis Nation of BC that's live throughout the province as well. So what's next? This has been a great success story so far for us, and so we're looking to expand to a little bit more services. So maybe you don't need the drug timer, maybe you need a little bit of something else. So we're looking at the problem of if we can connect to our banking, we can order an Uber for a ride through our phones and through an app. Can we also connect to mental health and emergency services? And the answer largely is not really. So we've looked at kind of what you might need in the app. So I've listed some things here. The big things really are connections to mental health services, speak to somebody immediately if you're in a crisis, protect yourself while using substances. So that's our timer. And then kind of looking at, okay, well, how do we find that right now? Well, people generally, they search online, they call 911, or they just remain quiet and they don't say anything, all of which are really not the most ideal situation for finding those services. So what we're trying to do is we're saying, hey, we're going to be that one app that you can go to for whatever services you need to be connected to. And we can be almost like a piece of a triage process to connect that person to said services. So just in summary, we've saved over 44 lives now with the use of Alone Timer. We're adding new features and expanding the application to new geographical areas as well. And really our overall objective is to connect users to the mental health and well-being support services. Feel free to reach out or check us out online. And I'd love to take any other questions or thoughts anybody has.
Awesome. Thank you, Colton, for the great presentation. We do have a question here. Thanks for the presentation, Colton. Your team is doing great work. How do you think the Lifeguard app can be integrated with other e-mental health platforms?
Ooh, that's a great question. We've actually had a lot of different conversations with different e-mental health platforms. There's one in the States called PhoneMed, I believe, actually, and they're throughout the States, and they provide services and triage services. Also 211 here in BC is a big one that we've talked to. So we're looking at several different partnerships to help really just build more connections that we can make and create more partners for more people to have more access to the right services.
Awesome. Next question. How will this app interface with other apps or resources already in development in BC?
Well, we don't really with other apps. Like I said, so we have
So I think Colton cut out.
See? Oh, have I cut out?
Oh, sorry. Yeah, you cut out for a second there.
Sorry about that. Yeah. All good now?
Yes.
Yeah. Okay, great. So we integrate with the BC Emergency Health Services. We integrate with different databases to keep our connections and resources up to date. But as far as with other apps right now, we haven't looked at that quite yet until we get into kind of the 211 and PhoneMed partnerships that I was talking about earlier.
Awesome. All right, next question. Hello from Saskatchewan. Is there any app such as yours that you're aware of that is available in other provinces? Or is there any movement on expanding to cover other provinces?
So yes, we're looking at expanding to cover other provinces. The tricky part for us is that we need an agreement with the whatever the paramedic service provider is in that location, so that we can set up the integration and make sure they're trained and able to respond to somebody if they overdose and create an alert through the timer. But what we're also doing right now is we're building out the app to add some more features, so some peer-to-peer supports, as well as kind of building more of like news feeds and communities in that, and that will be expanded to throughout Canada. Hopefully, give us a little bit more momentum, and then the initial jump of adding in the timer and the connection to emergency services will be a little bit easier to accomplish as well. So, yeah, looking into that at least right now for this year.
Next question. I have many patients using this. How many that were false calls? And how has this increased the resources of first responders, and are funding initiatives underway to support this?
Absolutely. Okay, so I'll see if I can break down that down. So very few false calls to start. I'll start with that. When we very first launched to the public, I think we had 2 or 3 in the first month that just kind of said, hey, does it work? Also, as part of the process for the emergency services side is as soon as they get the alert, they phone the person back on their phone to make sure that there's nobody, that there's anybody that can cancel the call, essentially is what I'm getting at. And since that, no, I think we've had maybe 1 false call or anything else is like a call back confirmed okay, we call it. So we call the patient back and the patient says, you know what, yes, I was nodding off, but I'm awake now, I'm good, and I'm okay. So it's not a burden for the EMS services. Sorry, Johnson, can you repeat the second couple parts there?
Yes, let me just find it again. I believe they're asking about whether this increased resources of first responders, and if you know of any funding initiatives that are underway to support this.
Oh yeah, thank you. Well, first responders are always strapped. We work very closely with the BCHS, so For us to decrease their resources or increase the capacity for their resources is a whole nother bigger problem. I know it hasn't been a burden for them, nor has it, I would say, really increased any capacity for them either. And then to the funding question, yes, absolutely. So we're a small business in tech in Canada, so we're available for several different grants that we have applied to, and different other additional projects through the Substance Use Addictions Program, which is a federal grant throughout Canada. And we have contracts with the ministry as well that help our funding situation as well.
Right, sounds good. Let's do one last question. So the person would have to have their privacy setting to allow their location to be known. Is trust a barrier to this?
That's a great question. It's not really. So what we found is people who are using this application, they're using it because, at the timer at least, they're using it because they don't want to die, right? They're protecting themselves. And we've intentionally built this application so that we don't track the user's privacy or their location. That information that you have doesn't leave the phone. It doesn't come to us. Or the personal information doesn't leave the phone unless there's an emergency triggered. And in that case, it just goes straight to EMS. The location services, the only thing that we can see is how many users were in what city. So I can say, there was 100 people who used the app in Vancouver yesterday, but their actual personal location, like their address, their name, any of that other information, we don't track that. We just treat it as anonymous and as possible to kind of prevent.
Okay, sounds good. And as a follow-up, does this person need to be tech savvy to have their settings ready to use this app?
No, you need a phone that has that can do text messages, because we have to do an phone number verification. Apologize if my internet's cutting out. The thing that we need is a Wi-Fi connection, and it's two or three simple steps after that, so it's pretty easy to use.
Awesome. Sounds good. Thank you, Colton.
Thank you.
Right, let's move on to our third lightning talk by Dr. Nicolau Bompari for his talk on the effectiveness of a web-based self-help tool to reduce problem gambling, a randomized controlled trial.
Thank you for the introduction. Are you sharing my slides for me? Oh yeah, perfect. Great. So hello, everyone. I'll present shortly our results from our randomized controlled trial of this web-based self-help tool to reduce problem gambling. So problem gambling can harm individuals' health, relationships, and leave them in substantial debt. And also there is a high rate of comorbidity with problem gambling and other DSM-5 diagnoses. Problem gambling is fairly common in the population, and we see that around 10% of pathological gamblers only seek treatment. And that's where digital health comes into use, and its potential to reach and support individuals affected with gambling-related problems, because it has a variety of advantages. So for our study, these are the inclusion and exclusion criteria, which I'll leave uncommented. So our design in our first arm of the RCT, it was our intervention, win-back control, and the second arm included an active control condition, to which I'll come back later. And we had assessment at 8 weeks and at 6 months. So win-back control included a variety of psychotherapeutic techniques and 5 core modules and 4 complementary modules. For the intervention, this is the dashboard, which gives a quick overview of the intervention progress. And this is the gambling diary that people in the intervention group would see, and they would be asked to fill out every day gambling related information and be able to monitor also how they gambled. So to the modules, these are the 5 core modules, which get released after everyone is filled out, and the 4 complementary modules which address comorbidities. This is the active control condition, which is a self-help manual, which has been shown in 2 previous studies to be effective. And that was also the reason why we used it. So all analyses are according to the ITT principle. We conducted linear mixed models for all outcomes and calculated coincidences to show how large effect sizes are. Oh, that's small, but good to see is that at 8 weeks, so from the 360 participants we randomized, at 8 weeks and at 6 months, there was a large dropout rate. The majority of people that we recruited were males. The mean age was around 33 years of age. The majority of people came from Germany, followed by Switzerland and Austria. So the primary outcome was a number of days of gambling over the past 30 days. And there we saw in both groups large effect sizes. However, there was no significant difference between those 2 active groups. However, we saw that according to the GSAS, cigarette use over the last 7 days and client satisfaction, our participants in the intervention group performed significantly better. And also noteworthy to say, according to the PGSI, the PHQ-9 and the GAD-7, participants in our in both groups, participants had large effect sizes, reducing their symptoms. So overall, high dropout rates, both interventions are effective and produce large effect sizes. However, win-back control in certain outcomes performs better. And given the optimistic results, our intention is to make win-back control freely available for public health purposes. Thank you for your attention.
Great, thank you for the presentation. I have a question. Have you implemented or considered implementing resources for when someone is in imminent danger or crisis on the web-based self-help tool?
That's an interesting question. So how we did it now is that we tried to recruit. First of all, we wanted to see if this intervention is effective before releasing it out to the public. And we use social media mostly to recruit people. And so everybody who saw an ad was able to make use of it. And now that we know that it is effective and there is no harm in using it, we will see how to keep it online and available for public health purposes.
Awesome. I have a question here. Can you speak to some similarities or differences between people dealing with substance use disorder compared to those dealing with pathological gambling?
That's a very interesting question. I think a very interesting difference is people who have who gamble in a problematic way. They often believe they can solve their problems by the source of their problems. So people believe, oh, if I just gamble a little bit more and make the money back, then I'll be fine. I think that's a big difference compared to substance use.
I see, thank you. I have another question. Have you run into any challenges with either implementing the self-help tool or running the study?
Of course, since we recruit widely and fully online without in-person screening, you have a lot of a big uptake. A lot of people sign up, but then the majority logs in a few times and doesn't use it, and then often you don't know why they don't use it. So that's why we had around 75% of dropout. And it's a shame. We would love to hear why people stop using it. But yeah, that's always a problem of digital health.
I imagine. Yeah, so no questions for now. I'll give another 10 seconds if anyone has any last questions. But if not, we can move on to our last and final lightning talk by Kelly McInerney on opioid agonist therapy for youth and young adults, a program evaluation at Foundry North Shore. I believe you are sharing your own slides.
Yes, I am. So I'll just share my screen with you.
Yes, please.
Okay, great. And okay, slideshow, where are we here? There we go. So hi, everyone. So I'm a nurse practitioner. I work at one of the foundries in BC. There are several, and this is Foundry North Shore. And I, for my thesis, for my clinical doctorate, completed a program evaluation of our opioid agonist therapy program for youth with opioid use disorder. And this is Foundry. A retrospective chart review was completed, and from the inception of the program, January 2018 to 2021. And it should be noted that this was during COVID, and which I think had an impact on data collection and on youth. I created a data collection tool which was vetted with experts in the field on measurement as well as clinical expertise in addiction. And there were a total of 23 young people identified with opioid use disorder. The data collection tool looked at 4 main foci: demographics and social determinants of health, which included things like age, concurrent mental health disorders. Were there any adverse childhood experiences noted? Characteristics of opioid use looked at things like when they initiated opioid use, which opioid they were using, mode of use. Patterns of treatment included things like for which opioid agonist therapy treatment they were on, which one they had switched to, were there gaps in care, and healthcare service utilization. And for today, I'll just focus on the external health services, not the ones pertaining to Foundry. And so this was adverse childhood experiences. So based on this, the score is 0 to 10. 91% had at least one adverse event up to and including 7 adverse events. So a total of 91 youth experienced adverse childhood experiences. And concurrent mental disorders, all of the youth in the study had at least one mental health disorder diagnosed with DSM criteria, and anxiety being the highest, followed by depression, and then, which was surprising to me, ADHD, which has huge implications for our practice and early screening and treatment. Characteristics of opioid use. So youth generally started opioid initiation at 17.4 years, but the age range was striking, and youth were starting to use opioids as young as 12 to up to 23. So again, have implications for program planning and harm reduction strategies. Mode of use, 70% were injecting, and opioid of choice, 80% were using fentanyl. Polysubstance use, which we know is prevalent in youth, all 100% of youth were using other substances, with benzodiazepines being the most commonly co-used, as well as cannabis or THC, and followed by crystal meth. And then, so I thought this was rather interesting. So even though first line, Suboxone is considered first line opioid agonist therapy in youth. Methadone was more commonly prescribed. And this slide is busy, but looks at patterns of OAT treatment. And really, so half the youth had tried OAT before coming to Foundry. Switching OAT was very common. Interruptions in care were seen frequently, and there were many restarts on OAT. So I think it's important for providers as well as youth to understand the care trajectory. And this is not a failure, but this is part of the treatment and recovery. Healthcare service utilization. So this is just a snapshot. There were lots of emerge visits and there were lots of overdoses. However, I think this is underrepresented because we really only found out about ones where people were seen in emergency. There were suicide attempts. Half of the youth had a hospitalization, which included visits such as psychosis, assaults, cellulitis. And so key findings of the study. So caring for youth with opioid use disorder, very complex and intense. There's a strong history of adverse childhood experiences and concurrent mental health disorders. Polysubstance use is widespread. A multidisciplinary team is really needed to care for these youth, and there was a very high level of acuity. So their health policy is one of the recommendations, and things that look at early intervention for youth and families starting at prenatal period, preschool, and early interventions. Looking at law enforcement paradigm to reflect more of a social justice lens and a move away from crime-oriented policing and to a more public health approach, which is occurring. And recommendation 2, service planning, looking at operational things. So just things like extending weekend hours, on-call hours, improving communication with our emergency department and our community substance use, and including police and ER in our acute care points in our program planning and service delivery, and improving take-home opioid agonist therapy program, which is underway at our local emergency department, and looking at prevention and harm reduction at all points of care, including early childhood and elementary school, even clinical practice. So I think it's useful to incorporate an ACE screening tool for all youth who are part of our program, and regular screening for substance use at all levels of care, including schools, Foundry drop-in medical clinics. Future research. So this was a chart review. And of course, there's always limitations with just if it's not documented, it's not there. And this did not include our youth. So the next study should really look at incorporating youth perspective and what are their goals for their care, and further defining what adherence on OAT may look like. And that's it. So happy to take any questions.
All right, thank you, Kelly. If any questions, please feel free to drop them in the Whova Q&A. I have a question. What would you say is one of the most surprising things you've learned through the study?
Well, I don't know if it's surprising. I think concurrent mental health disorders in the literature are quoted as, at 50 to 63%, and all youth had at least one. And I really think, a diagnosis of ADHD is probably underrepresented, and it's a bigger problem than maybe I would have anticipated. So that would be surprising. And also, the range of opioid initiation and starting at 12 was I thought that was quite shocking. There were quite a few surprises. But yeah, that lists a few of the top ones for me.
Great. All right, we have a question here. Can you tell us more about the transition towards a social justice lens from the current models?
So I think, and I actually think they're doing this on the North Shore. So like Foundry is a province-wide initiative, as most of you know, and there are, I think there's 12 in operation and there's 8 more under development to serve the health of youth, like integrated services, one-stop shopping. And so when I think we look at a social justice lens for substance use, instead of like having a crime-oriented policing, involving our police with the care and the program planning, because it's really youth, and in this study was quite large. And one of the things that came out of it was there were many police encounters. And of course, because of confidentiality, I couldn't access actual data on police records. I was able to see that like a lot of youth were having mental health crisis, and police were needed to bring those youth to the hospital. But just having a format where this is a great opportunity to serve youth, see youth, get them maybe the urgent care that they need, but the linkage or connection to substance use services at that time, I think is a critical piece that we could be doing better. And I think from what I can see, we have police liaison on the North Shore that are interested in doing that as well and being part of the solution, rather than just, you know, picking up the youth and bringing them to the emergency department during crisis. So did that answer the question? That was a piece of it anyway.
I believe so. Another question, great talk. In the experiences of accessing OAT in hospital, is that peds or addiction medicine that take the lead?
Well, that's a great question. So I think it depends on which hospital. So, and this is some hospitals, some of the downtown hospitals are very experienced and have a smooth process for introducing or initiating OAT in emergency departments and have addiction care services. Some of the smaller hospitals are just getting started with offering OAT in emergency departments, and most of the smaller centers don't have specific addiction services. So, and I really, because I work in community, I'm aware that they are working on, from our local hospital, working on initiating OAT, but I don't think the pediatrics would be small there. And I think that would be done by general medicine. So, and I don't know what their program's going to look like, but great question.
Yeah. Another question, can we access this information in a link for further study later?
I think you can have access to my slides, and I do have several pages of references that I didn't put in, but I'm happy to share those if anybody wants those.
Yeah, but I think it'd be great if we could maybe drop that in the Zoom chat or on Whova.
Sure.
Yes, I think so.
Sure. Oh, and one other comment. I'm just thinking of addiction services. So at the hospital that I work at, there is a service called Carlisle where youth can go for addiction services, and that's up to 19. So, but Foundry serves youth up to 24 in the community. So.
Awesome. Next question. Is it the practice to share these findings with other Foundry sites? And is there a provincial strategy to address some of these findings?
So yes, this was my thesis that has just been completed in December, and I have shared the findings with Foundry Central. So it's the umbrella of all the foundries in BC, and they have head researchers there, and they're working on projects. And actually, they have currently, I think Dr. Barbic and Dr. Marchand are working on studies to include the perspectives of youth, which is sort of where we're at. So they're doing Foundry wide. So there's many initiatives that are underway within the umbrella of Foundry.
All right. Given that housing first is a need, what kind of liaison exists to offer it in conjunction with healthcare?
So that is a challenging one. So, so there are counseling services, we have intensive case management, we have a substance use nurse, and those services often will be involved in trying to help youth with access housing. But it's a challenge. But the interesting thing with this study in this location was that most of the youth were, well, not all of them, but most of them were housed. They did have one parent involved in their care, which might look very different if you were looking at another Foundry Center, such as one in the downtown area. So interesting. I mean, the problem was the same with opioid use, but housing was a bit different. However, we do have our youth who have housing issues, and it is a big struggle because there's a real lack of housing.
I agree. And what kind of version of ACE questionnaires do you recommend using?
So there is the original one from CDC, I think it's a one-page question with 10 questions that could be put on Toolbox, like on some computer format. So youth are just filling it in as part of their intake information. I think it would be easy enough to do that, like a one-page screen, which I think was the original from CDC, from Kaiser. I think they put it out. And that'll be in my reference list as well, the ACE screening tool.
All right, great. What kind of interventions do you recommend to prevent ACEs?
So that is like a whole topic in itself. And, you know, I don't pretend to know like public health initiatives. I'm sure there are a lot of them, but there's still evidence that supports really having more robust services for young families and families who are vulnerable, who may need jobs, housing, parenting skills. So I think supporting young families early on will help youth, and supporting families who may have a youth who has some learning disorders and on top of that may have some mental health disorders early on so that they get the support and have less stress within the family, I think are all good initiatives. And I'm sure a lot of those things are underway, but I think we're still missing quite a large portion of people.
Great. And is there training provided to those who are completing their ACEs documents with the individual?
So great question. So ACE is really, it's a screening tool, and Foundry provides trauma-informed care to all the youth that they see. So the idea, and you know, there's a lot of evidence that supports doing this screening tool, but it's not an opportunity at that time of screening to start doing trauma-informed counseling. It is a screening tool, just like you would do a substance use screening tool to see if there were any alerts that you needed to attend to. I think we do have many counselors that do, well, we all do trauma-informed care, but there are counselors that can provide that if needed. But where we're coming from is the information it does two things really. It helps providers be on the same page when they're seeing a youth for the first time, because sometimes we will see we'll see patients that we may not know for prescriptions for OAT. So it's a good communication tool for providers, but it also helps youth not have to repeat their story again and again. So it's not to get a fulsome history of a trauma, it's to know if any of these were alerts, and then to look at that score and understand the youth's perspective to care. Great question, because sometimes, you know, it's easier not to ask that question. And so you don't have the information, but so this is, it's just a screening tool.
Awesome. Well, I believe that brings us to the end of our questions. So thank you everyone so much for your thoughtful questions. And also a big thank you to the speakers for your awesome presentations. They were all very well done. So this brings us to the end of our Block 1 lightning talks. For the audience, please remember to vote on the poll on Whova for which talk you like best. And the next block of workshops is going to begin at 10:35 Pacific Standard Time, so in 25 minutes. So please feel free to take a quick break until then. And I believe we will be posting the recording of this lightning talk on our YouTube channel. So thank you, everyone, and please enjoy the rest of the conference.